Welcome, everyone, to a special episode of the NRG Oncology Podcast, focusing on hot topics from the semi-annual meeting in Phoenix. We wanted to bring to you a couple of initiatives really being pushed by NRG Oncology leadership. The first initiative we're going to explore is the new NRG Oncology Theranostics Committee being launched this year.
The new Theranostics Committee is being led by Dr. Jeff Michalski, who has had an illustrious career in academic oncology as the vice chair of radiation oncology at Washington University in St. Louis. He's also served as president of the American Society for Radiation Oncology and is the former chair of the Radiation Oncology Committee here at NRG Oncology. He's led numerous clinical trials and other research that has advanced cancer care for patients.
On a personal level, I've known Dr. Michalski for a long time as a friend and mentor when I was a medical student, resident, and junior faculty at WashU in St. Louis. So, Dr. Michalski, you've done so much in oncology, probably more than Stephen and I might do in our combined careers. You've literally been, as we would call it, to the summit of Mount Everest. I think all of us would agree you probably deserve to be sipping a Mai Tai in the Bahamas or something. What is motivating you to get involved with the amount of work in a new initiative like launching a new Theranostics committee at this stage of your career?
Well, Lauren, thank you for the introduction. Stephen, thank you for the introduction. I'm very happy to be a part of this new initiative for the NRG. As you pointed out, Lauren, I have been on the ASTRO board as president and chair of the board, and my tenure on the board of ASTRO is winding down. As of the next annual meeting, I will no longer be on the ASTRO board, and I will have a lot more time to give to new and interesting committees and activities in radiation oncology. I also, a few years ago, after having been chair of the Radiation Oncology Committee for like 15 years, I stepped down from that position because I wanted to give some of the younger members of NRG an opportunity to ascend in the group and get involved in more research. Since that time, I've kind of missed that leadership and mentorship opportunities. And so I figured with a successful track record of establishing new committees in the NCTN, I thought that with this new opportunity being made available, I would give it a go. As you're aware, Lauren, myself and others at Washington University have been involved in the radiopharmaceutical management of cancer patients for decades. In the days when radioiodine was the only effective theranostic, we were administering that. And then with the advent of Lutathera, lutetium dotatate to treat neuroendocrine tumors of the GI tract, that came to radiation oncology. And then with lutetium PSMA therapies also came to radiation oncology. And so we felt that establishing a new Theranostics subcommittee, actually a subcommittee of the Radiation Oncology Committee, would make great sense. And my experience both locally and nationally, I think, gives me an opportunity to lead and mentor new investigators in this very exciting space.
So, I'm going to have to admit that while I, in the general sense, know what theranostics are, I mean, you've already mentioned Lutathera, you've, mentioned lutetium for prostate cancer. I am not particularly well versed in this stuff. And I think I'm speaking for most physicians when I say that none of us are probably taught about this in medical school, and very few of us learn about theranostics, even in residency training for radiation oncology. I think even the term theranostics doesn't intuitively tell us what this stuff is. For our audience out there, can you expand a little on what exactly theranostics are in layman's terms? And maybe if you can break down those two examples that you spoke about for prostate cancer and neuroendocrine tumors.
Yeah, certainly, Stephen. Great question. The word theranostics actually has a Greek origin. Therapia means healing or to minister or treat medically, and gnostic means knowledge or insight. And so think of theranostics as having knowledge or insight into the whereabouts that cancer might be, and the therapy is being delivered systemically. And so it combines the imaging of nuclear medicine along with the therapy of a systemic radiation treatment. And the important thing about theranostics today, unlike what I mentioned earlier with some of the older radiopharmaceutical drugs, is that we really need to have a partnership with our nuclear medicine colleagues. And I'm really proud of what we've been able to establish at Washington University in terms of a theranostics center that is co-led by a radiation oncologist, Hyun Kim, and a nuclear medicine physician, Vikas Prasad. And it's important to have that relationship because nuclear medicine physicians are the experts in terms of interpretation of medical imaging. And they help us select patients who might be appropriate for these theranostic treatments. It's not just a matter of seeing something light up on a PET scan that determines whether or not a patient is a good candidate for a treatment using a tracer that targets that same area of uptake. In fact, we had an example this week of a patient who had bone metastasis from prostate cancer, and the PSMA PET scan was positive. But if you look closer at the imaging, you see that the uptake was actually in the marrow, not in the cortex of the bone. And so for that patient, we might have considered radium chloride, but because it was bone marrow disease, we really felt that lutetium PSMA 617 was a more appropriate therapy. So having that interaction, that conversation between nuclear medicine and radiation oncology is really important. And of course, radiation oncologists bring to the table, a lot of clinical expertise and clinical trial expertise in therapy. We see and do physical exams on our patients day in and day out, and have the infrastructure to not just do consultation, but also to follow the patient longitudinally in our clinics. And the other thing that radiation oncologists bring to the table is a very keen interest in radiation dosimetry. I don't think we ever treat a patient where we can't explicitly state the dose that the tumor is going to be getting and the organs at risk that we're trying to spare. We know what doses those organs are getting and decide the amount of radiation to give based on what the tumor is getting and what normal tissues might also be getting. And so those two specialties, diagnostic radiology, nuclear medicine, and radiation oncology, I think work very well together to deliver, optimum therapy for these types of patients.
It seems like NRG Oncology really aims to get involved in theranostics in a major way through this new theranostics subcommittee that you're leading. What do you foresee as the future for theranostics, and how might this committee play a role? And maybe more broadly, why is the NCI getting interested in theranostics at this moment to expand indications?
I think with the availability of these two new agents, Lutathera, lutetium dotatate, that is, and lutetium PSMA 617, has really demonstrated the opportunity that systemic radiopharmaceutical therapy has for patients who have metastatic cancers and have kind of run out of opportunities of systemic therapy with chemotherapy or local or regional therapy with radiation. And so these two drugs have demonstrated pretty strong activity, prolonging patient survival, improving their quality of life. And now that those two are available, there's a whole catalog of treatments that are undergoing investigation today, mainly by pharmaceutical companies who have entered this space, or by single institutions that are acquiring these through the NCI, through different acquisition mechanisms. So I think the NRG really needs to be involved in this because it really is the future of cancer therapies. By itself, these treatments may not be curative, but in combination with external beam radiation, in combination with surgery, in combination with other systemic agents, I think that these treatments will improve patient outcomes. So I think that these radioactive drugs are a very exciting opportunity to deliver a systemic therapy to cancers that we might not have been able to treat before.
So I want to delve into something that is probably on the top of every cancer patient's mind. And the question is, can I be cured with theranostics? Do you see theranostics as something that has the potential to cure more people, or is this something that's more on the lines of going to help us turn cancer into a chronic disease? I think of diabetes or high blood pressure. With diabetes, we treat it. Same thing with high blood pressure, many good medications, but we don't really cure them. What do you tell a patient asking, if this has the potential to achieve more cures?
That's a great question, Stephen. And I think today, as we are using these drugs, they're not curative therapies. But think of other treatments or other diseases, that is, that treat with systemic chemotherapy, knowing that these drugs by themselves aren't curative. But as we identify that there is some activity in these cancers with these systemic therapies, we see them perhaps improving disease-free survival in patients who have late-stage metastatic cancer. And then we move them up earlier in the condition as adjuvant therapies for patients who have perhaps resectable disease, but we know that the risk of microscopic metastatic disease is significant. And so we test those drugs we know to be active in late stages, but now in an earlier stage, and as an adjuvant, they've improved patients' survival rates. And so that we see this happening with lutetium PSMA 617 and other lutetium PSMA directed therapies. We know that they're active in patients with hormone refractory, taxane resistant metastatic prostate cancer. And that is right now where the indication for lutetium PSMA 617 lies, is that we give it to patients after they've failed hormone therapy and taxane-based chemotherapy. But interestingly, we've just completed clinical trials testing the same radioactive drug in patients who have castrate-resistant prostate cancer, but prior to them receiving a taxane-based chemotherapy, so the pre-chemotherapy space, if you will. And that study was presented at the ESMO meeting last year, the European Society of Medical Oncology, by Dr. Oliver Sardor, our co-chair of this Theranostics Subcommittee, and it's called the PSMA-4 trial. And that showed that it improved disease-free survival in men receiving lutetium PSMA versus a new androgen receptor pathway inhibitor. So in the pre-chemotherapy space, there looks to be some benefit. And another trial that we completed and is still probably a few years from being reported is a PSMA addition trial, where we treated patients who had castrate-sensitive cancer and randomized them to receive standard androgen deprivation therapy versus that same androgen deprivation therapy with lutetium PSMA 617. And one might hope that those patients who receive the radioactive drug will have better survival than those that were treated just with the systemic hormone therapy. And here's where I think the opportunity for NRG lies, is what if we take patients who are not metastatic, but just have a high risk of having metastases and treat them with these radioactive drugs? Might we prevent patients from moving from a local regional high risk condition to a metastatic condition with the use of these radioactive drug agents? So, I think, your question, can we cure patients with it? Not the population that we've been treating so far today, but perhaps as an adjuvant to other therapies, it may very well be an important component of that.
There's a line in the movie Back to the Future where Emmett Brown tells Marty McFly, "You can't just walk into a drugstore and buy plutonium." And while I say that tongue in cheek, it is true that you need fairly sophisticated infrastructure and support to handle radioactive stuff, or unsealed sources if we're going to be technical. What kind of infrastructure are institutions going to need to run the future theranostic trials out of NRG oncology? And within NRG oncology, it seems like a lot of work that might be supported or driven by radiation oncologists. While a lot of institutions may handle theranostics, at least in part through nuclear medicine, can you speak a little bit about who an authorized user should be and the quality assurance and training needed for a clinical theranostics program?
Great question, Lauren. And I like your Back to the Future analogy. I have to say, I just was able to attend at the Fox Theater the Back to the Future musical, and it brought back a lot of memories from when that movie first came out. And yeah, you can't buy plutonium at a drugstore, and you can't get lutetium at a regular pharmacy either. Yeah, having the infrastructure in place to administer these drugs is very important. Sometimes I take for granted the infrastructure that we have here at Washington University. Those centers that are reaching out and trying to strike out on their own and establish a theranostics center may not have the luxury of all the people and resources that we have here today. But it's not impossible to start this. And if I was a radiation oncologist or a nuclear medicine physician or even diagnostic radiologist at a center less supported by the infrastructure that we have, first thing I would do is go to the radiation safety officer. There's going to be a radiation safety officer at nearly every medical center because of the use of radiation in diagnostic imaging and nuclear medicine, and also in radiation oncology. And the radiation safety officer is going to be your individual who will understand the necessary components of a theranostics program. That being said, the authorized user status has been a real important conversation in radiation oncology and nuclear medicine over the past couple of years. As you know, these are governed by the United States Nuclear Regulatory Commission, these radioactive drugs and other nuclear byproducts. And you have to have a certain number of hours of training and experience to become an authorized user for brachytherapy and for radiopharmaceutical therapy. So the NRC has guidelines that state specifically how many hours. It's like 700 hours of training in the management and handling of radioactive materials and management of patients who are receiving radiation therapy. And a certain amount of this has to be classroom hours, and some of it can be obviously hands-on clinical experiences. And so I would encourage people to talk to their radiation safety officer about what does it take to become an authorized user. The other thing is ASTRO has considerable resources on the ASTRO website, and I'd encourage people to go to the ASTRO website and see, what are some of the frequently asked questions and answers about how to become an authorized user. And the ABR this past January decided that they would no longer certify candidates to become authorized users. And the reason for that is what the ABR was doing was basically attesting to the NRC that the candidate who was applying had undergone and received the necessary classroom hours and practical hours of training. But it really was them attesting to an attestation that was already provided by the training programs. And so what they've done is they've pushed the management of this documentation regarding training and experience back to the training centers, back to the residency training programs. And so today, to become an authorized user, if you're in a residency program now, you're going to want to have your program director carefully document the hours and experience that you've had during your training so that you can then bring that to the radiation safety officer to your new program to become an authorized user. They need to put you on their license. Here at WashU, we do the residents a favor by putting them on our license for radioactive drug therapy before they finish their training. And so everybody who leaves our program leaves as an authorized user. But if you're at a residency program in radiation oncology where you aren't administering these drugs, you can go to the Department of Nuclear Medicine and observe or participate in the treatment of some of these patients who are receiving these. Or what we're exploring is developing a training program where people can come from outside St. Louis, come to St. Louis and observe us to do those. And so we're verifying that that type of training will pass muster with the NRC. But I think bottom line is you'll want to go to your radiation safety officer. You want to communicate with your residency program director to make sure that the training experience has been well documented. And there are ways for you to get the AU status. Now, once you finish your residency, you have just 7 years to become an AU. And once you're an AU, you're an AU forever. But if you don't get it before 7 years, you might need to do some extra training. And ASTRO has been developing a master class that is offered at the annual meeting. And we also have a curriculum called Beyond the Beam, which are 15 hours of now online instruction on using radiopharmaceutical therapies and some of the basic science behind it and some of the radiation safety aspects. I'd encourage you, even if you are an AU, it's still a good curriculum to watch because you'll learn a lot by participating in that 15-hour curriculum. But anyway, it is a process. It is governed by the US NRC or in agreement state by the state government. And your radiation safety officer is going to be your best friend as you consider how to start up a theranostics program. I said a lot that sounds like it's really hard and difficult. I think when you start peeling it away, you'll find that it's not impossible. It is an achievable status to get for yourself. And I'd encourage people to do it sooner than later because I think these drugs are going to be available for more than the current indications and for more than just the two cancers that we have already discussed, the neuroendocrine tumors of the GI tract and the metastatic prostate cancers. I think we're going to see it available in breast cancer, head and neck cancer, brain tumors, leukemias and lymphomas. So I think it's definitely worth spending the time to become an authorized user. Another resource that I would point people to is our Chief of Brachytherapy Physics, Dr. Jacqueline Zoberi, has taught at the masterclass. She's been part of that curriculum that I mentioned. She also published a paper in the Journal of Applied Clinical Medical Physics, but definitely a lot of resources that people can avail themselves to become AU and to start up their own program.
So I think, especially for someone who's been doing clinical trials as long as you have, you would likely affirm that, as with many things in life, collaboration is key to success. And in that spirit, I'd also like to point out that the work of the NRG Oncology Theranostics Subcommittee isn't happening in isolation. Could you also fill in our listeners on the collaborative work you've already been doing with the American Society of Radiation Oncology Theranostics Working Group?
Yeah, thank you, Stephen, for that question. And I have to, give credit to people like Anna Keese at Hopkins and John Boatti at the University of Iowa, who helped reestablish the radiopharmaceutical working group in ASTRO. And they actually have some white papers and papers on how to establish a theranostics program in your own radiation oncology department or in your own nuclear medicine department. It was kind of agnostic in terms of specialty. ASTRO also has an annual master class. It usually takes place on the Saturday of the annual meeting and goes for several hours. And if you're looking for classroom hours to count towards becoming an authorized user, that certainly would work. This year, we also added a 1-hour theranostic session in the practical radiation oncology program that also was on a Saturday. And as I mentioned earlier, we created a Beyond the Beam curriculum for people interested in becoming authorized users and bringing the radiopharmaceuticals to their own clinics. Myself and other leaders of ASTRO have met with the leadership of the Society of Nuclear Medicine and Medical Imaging, SNMMI, and we are talking about having a collaborative meeting, hopefully a face-to-face meeting, where we can bring disciplines together. We also established a radiopharmaceutical roundtable and just hosted the second of what we hope to be an annual meeting at ASTRO headquarters, where we meet with industry to talk about what their concerns are and needs are from the radiation oncology community. And some of the things I talked about, like becoming authorized user, like establishing a new program, are of keen interest to industry. And one of the things that we would hate to see is these promising and very effective drugs disappear because of lack of infrastructure. You might be familiar with Bexar, a very effective treatment, malignant lymphoma, that basically disappeared because the infrastructure, the number of hurdles that medical oncologists had to take to refer a patient and get that treatment for their patients was very complex. And I hope we've learned from that lesson and realize that a collaborative relationship between our nuclear medicine colleagues, our radiation oncology colleagues, and medical oncology colleagues can be much more effective to get these promising treatments to our patients.
Well, Dr. Michalski, I want to thank you again for joining us. I also want to thank you for all the work you're doing with the new Theranostics Subcommittee. I think this is going to bring us a really exciting new tool to help us move the needle forward for our cancer patients.
Stephen, thank you very much. It's been my pleasure meeting with you and Lauren today. I have to say, I've listened to some of your podcasts and really find them enlightening, informative, and fun. And I'm glad to be part of this one today. Thank you very much.
Our next guest for this special episode of the NRG Oncology podcast from Phoenix at the semi-annual meeting here is Dr. Joan Walker, who's a professor of gynecologic oncology at the Oklahoma University College of Medicine. And she's had a long career with NRG Oncology as the co-principal investigator of the NCORP program. Some of the big news coming out of this January 2025 meeting is that Dr. Walker will be stepping down as co-principal investigator of the NCORP program. This is a role she's held for over a decade. And for our listeners out there who might not be familiar with it, the NCORP program is the NCI Community Oncology Research Program. I think for many out there, NCORP is sort of a mystery. Dr. Walker, I know that many of us know it's an NCORP trial when we see the letters CC that appear before the trial, like CC009 for brain metastases and small cell lung cancer. Could you just give us a brief overview on what exactly NCORP is and what your job as the NCORP co-principal investigator has entailed all these years?
Sure. Well, NCOR is funded by the Division of Cancer Prevention at NCI, and their mission initially when launching NCOR was to bring the late-breaking cancer treatment options to community oncologists. So the usual NCTN distribution of clinical trials misses a lot of patients in rural communities and in underserved communities. And so NCOR launched to bring the opportunity to community clinical oncologists to apply and set up hundreds of NCOR sites throughout the country and bring access to clinical trials to those patients and those physicians. So those are called the NCOR sites. The NCOR sites, the NCOR mission is also to bring cancer prevention to the oncology community. And so that's my focus actually, is cancer prevention, preventing ovarian cancer, preventing cervical cancer, preventing endometrial cancer is my passion and why I practice medicine at this point in time. The NCOR also has a mission of supportive care. So rather than just focusing on treatment outcomes, the NCOR focuses on patient-reported outcomes, patients' toxicities to treatment, and health disparities, health equity, cancer care delivery research, which means implementation science, bringing the well-known practices to the community sites to implement them. For example, genetic testing, and then implementing cancer prevention surgical procedures in order to prevent cancer. All those sorts of things are implementation challenges when a new way of managing patients comes to market. For example, doing genetic testing or tumor testing to identify biomarkers of response to an agent. So for an endometrial cancer, we now categorize each patient based on their testing to determine whether they get Herceptin or another HER2 agent, or whether they get Pembro, or exactly what is the best treatment for each individual patient. That has been a profound change in care for lung cancer, for example. So that's called implementation science, to bring those practices to the community oncologists and implement them so that they become standard of care in reality, and the patients have access to it.
For many of us in academic medicine, I think in the general sense, figuring out the right time to move on and evolve from a role, especially one that you've been successful in, can be a real challenge. What has motivated your decision to step out of your NCORP role to focus on mentoring?
I am just being realistic. I'm turning 70, and the grant application that we are applying for renewal of our NCORP is a 6-year term. And both of my sisters died within that time period, as well as my parents. And so I don't want to harness or inhibit NCORP's success by my health or longevity. And so I am not going to change my passion or my interest in cancer prevention, but I am going to make NCORP succeed in continuing the cancer prevention after I'm gone. So I'm not disappearing. I'm very passionate about NRG and NCORP, and will continue to advocate for clinical trials that I think need to be done and promote the young investigators who are very, very competent at doing this job into leadership roles. So there's a half a dozen people I've contacted to apply for the cancer prevention position in NCORP as a deputy PI in order to gain their wings and take off. We're recruiting people from GYN and from breast, and people who maybe are basic scientists even, or clinical researchers.
Well, I think I speak for everyone that we certainly hope you're around for much, much longer. One of the initiatives that NRG Oncology leadership specifically asked us to highlight in this podcast with you is the NRG Health Equity Fellowship, which I believe you founded a number of years ago in 2021. Could you also tell us about the history of this program and why you wanted to focus on mentoring through this program at this stage of your career?
Well, it's obvious that even with the NCI funding that we have, even with NCTN and NCORP, we are failing to change the mortality discrepancy or disparities amongst our patient populations. So we are neglecting the rural populations, we're neglecting the underrepresented populations. And with that health equity focus, we felt it very important to bring people from those populations into our organization with mentorship to become the new leaders of the NRG Oncology organization. We have fabulous leadership. I'm not discounting that, but we have not done a good job of turning over leadership positions and promoting young people into leadership positions. So we made a very directed approach by getting $50,000 for each individual that we recruit to become focused on health equity and to represent their communities, and to help us to write clinical trials that are very directed towards eliminating disparities in healthcare, especially in cancer care, cancer prevention, and cancer control. So we have been very successful. We had, I think, 19 applications this year for 3 funded positions. Those funds is only being obtained through philanthropy. We cannot use the NCI funds for this purpose. And so through philanthropy with the collaboration of the pharmaceutical companies and through private donors, we have been able to fund 3 people this year. So obviously that's $150,000 that we have committed for 3 individuals who are unbelievably talented, representing the communities that are in need of changing of their healthcare in order to improve their mortality outcomes. Our country has a big problem with mortality in a variety of communities, mainly the African American communities, but there's many more. As I said, rural is a big problem for us as well.
For future applicants out there to the NRG Health Equity Fellowship, what is the selection process like, and when should one apply? Do you encourage pre-application inquiries to see if someone interested might be appropriate, for example?
Well, everyone is welcome. We had quite a variety of applications this year, mainly people willing to commit to a passion on improving health equity. The goal is to have them also be committed to creating a clinical trial, which will overcome the disparities that we see. And that's a tall order. We will then be mentoring and training those individuals to make sure they understand how NRG works, how to submit a concept, how to get that concept through and into a protocol, how to get through the NCI review process. All of that training will hopefully create new leadership. That's the future goal. We have basically 3 goals. One is health equity, improving access, consenting for clinical trials, improvement in enrollment of clinical trials, improving the design of clinical trials. And we want career development in underrepresented minority populations and rural populations, and designing the clinical trials to decrease disparities. So that's the goal of the Health Equity Fellowship. The criteria is really just that you're in the beginning of your career, you do not have R01 funding, and you're not already, mid-career. You're in the beginning of your career, you need a leg up in order to get that boost necessary to become successful and become a leader in our organization, and that you are willing to commit to trying to work on the problems that we see within our organization and within our cancer research portfolio.
And in the spirit of promoting that next generation that you've articulated so well, I wonder if you could talk about perhaps 1 or 2 of the program alums. I know it's a fairly new program established in 2021, but are there perhaps 1 or 2 alums of the program you could speak about and some of their early accomplishments?
It's been very amazing to work with these incredibly brilliant young minds. One of the fellows, for example, went into the databases of NRG to identify who we were enrolling on treatment trials versus who we were enrolling on the translational science components of those trials. And there is definitely a problem in getting people to submit their blood and tissue in order to get enough laboratory science done to understand disparities. And so we have to learn how to better consent patients, how to better recruit patients in order to gain the laboratory science, translational science database that we need in order to find out why we have the disparities that we do. So that individual's obviously done a fabulous job, Dr. Cameron. And then we've got Dr. Castellano, who she's mainly been interested in endometrial cancer and trying to understand why African Americans are so much more likely to die of endometrial cancer. She's been working both in her own community in New Orleans as well as on the Health Disparities Committee to try to figure out how to enroll African American patients in translational science programs where we can find out why they are so much more likely to have very bad cancers and have very lethal outcomes. And try to see if we can't bring the more advanced treatment options specific to each individual patient based on their KRAS testing or their NGS testing, so that we can treat them up front with the right agents at the very beginning of their diagnosis rather than waiting till they recurred, which is too late.
Thank you for all the work you've done with that program. I think it really is one of the gems of NRG Oncology, the Health Equity Fellowship. To finish up today, I wanted to actually return to the NCORP role that you hold. And I wanted to find out from you if you have any idea what the timeline is going to be for selecting your successor, and what words of advice would you have to your successor going forward regarding the challenges of NCORP in the future?
Yes, the application is online and it has been broadcast through the NRG broadcast through email. It's due February 14th, 2025. And there's actually two applications in mind at this time. One is for cancer control leadership and one is for a deputy PI leadership role. So those applications should be coming in over the holidays. We will talk about it in January at the meeting, but they'll be due February 14th, it says in the application process. So the people who apply for this have to be willing to reach out to the entire country. You know, all of these health equity fellows are all over the country, Kansas to Mayo Clinic to, as I said, New Orleans and New York. We need people from all over the country. We need people to be interacting with the NCORP sites, the community sites, as well as the cancer centers, the NCI designated cancer centers. So you have to be willing to work with all of the NRG sites and all the NRG investigators, as well as DCP. I've had a wonderful relationship with the DCP leadership. I go to all the cancer prevention meetings across the country, make sure I keep in touch with them and learn what their interest areas are. And we have to also worry about their funding, whether NIH is going to keep the funding that they've had for so many years in order to continue to sponsor NRG and NCORP. And so the challenges, I think, in the future are just maintaining the budgets that we have so we can do the work that we're trying to do.
Well, Dr. Walker, I want to thank you again for joining us today and all of the work you do and have done for community-based oncology research, as well as with the inclusion efforts at NRG Oncology. The big news coming out of the January 2025 meeting is that Dr. Walker will be stepping down from her role with NCORP. As she just mentioned, if anyone is interested in these roles, the deadline, I believe, is February 14th, 2025, Valentine's Day. The NRG Oncology Group is supported by grant funding from the National Cancer Institute, and content of this podcast does not necessarily reflect that of the National Institutes of Health. Thanks, everyone, for listening, and happy clinical trials.